Good afternoon, everyone. I'm Catherine Gascon, a perinatal consultant for the Champlain Maternal Newborn Regional Program, or what we call C1RP. If you don't know C1RP, we are a regional program whose goal is to improve perinatal and newborn care in Ontario Health East. Our extended network include representatives from hospital, midwifery practice groups, public health units, community health center, birth center, and other community agencies that provide perinatal and newborn services. Today, we are happy to collaborate with Dr. Jasmine Gandhi, Beth Tupela, and Christina Quentin for this fourth webinar, part of the Ask Masi webinar series called Let's Talk About Attention Deficit Hyperactivity Disorder, or ADHD. Before we get started, I simply wanted to remind you that this webinar is being recorded and that the video will be available on the C1RP website in the coming weeks. I would like to start by recognizing that many participants today are located on traditional Indigenous territories across Ontario. I acknowledge the land on which I am located here today. I am in Ottawa, which is built on the unceded Algonquin Anishinaabe territory. The people of the Algonquin Anishinaabe Nation have lived on this territory for millennial, and we honor them and this land. I encourage you to reflect on the land you are on, who the traditional keepers of the land are, and what the treaty relationship is, or if it is unceded territory. We recognize that there is much work to be done to honor Indigenous women and families' pregnancy's journey and to bring reconciliation to healthcare in Ontario. We acknowledge our role in collaborating with Indigenous peoples to raise awareness and challenges in the perinatal period and pledge to contribute to ensuring clinical perinatal care is done in a respectful and safe manner. We are grateful for the opportunity to work and live on this land. We remain committed to and acknowledge responsibility for building and improving relationship with First Nation, Inuit, and Métis people. Let us move forward in a spirit of reconciliation and collaboration. Now, before we get started, I just wanted to introduce our speakers for today. Beth Tupela is a registered nurse with 15 years of experience. She has worked in 3 different provinces prior to her work with Ask Masi. She was involved in opening and operating the first hospice residence in Nova Scotia. Beth is currently completing her MBA at Carleton University and is working towards her formal project management professional certification. Dr. Jasmine Gandhi is the medical director of the perinatal mental health at TUH, the Ottawa General Hospital, and an assistant professor of psychiatry at the University of Ottawa. Her academic focus is on improving equity in perinatal mental health care delivery, as well as medical education in women's mental health, consult liaison psychiatry, and interprofessional psychotherapy. And last but not least, we have Christina Quentin. She's a nursing research scientist at the CHEO Research Institute. You may be familiar with Christina as she worked with C1RP before and was heavily involved with the inaugural of the Ask Masi program. Christina will be moderating the Q&A at the session, at the end of this session. So please make sure to put your question in the Q&A box and we will answer them at the end of the webinar. Now, I will leave it to Jasmine and Beth to officially start our webinar today. Thank you.
Thank you so much, Catherine. So before I begin, I'd just like to understand a little bit more about who's actually with us in the room today. So if you could fill out that poll, just so that we have a sense of who we're speaking to and so we can tailor to the discussion accordingly. So I'll give you a minute to do that. All right, let's see. Okay, we have quite a few public health nurses and nurses, a few social workers, and welcome to the physician, I think one, and one person from child welfare. That's excellent. So I'll just read it for the recording. 4% physicians, 17% nurses, 52% public health nurses, 9% social worker, and 4% child welfare. Thanks so much, everybody, for answering that poll. And if we can go to the next slide, please. So just in terms of disclosures, this program, Ask Masi, has been very generously supported through Daymark Foundation. It's an unrestricted educational grant. So apart from that, no conflicts of interest to disclose. And then if we could go to the next slide for our learning objectives today, we are hoping to leave the webinar being able to describe the prevalence and impact of ADHD on people in the perinatal period, to recognize the signs of what unmanaged ADHD might look like when you are encountering people in your practice, and to describe the basic management and prescribing principles for ADHD during pregnancy and lactation. And for each of you to be able to ask Masi any additional questions about resources, referrals, and prescribing for ADHD in the context of the perinatal period. So maybe we'll ask another question to begin with. How confident do you feel in identifying concerns about your patient or client's ADHD? And how confident do you feel in supporting your patient or client's ADHD during pregnancy and postpartum? So I'll give everybody a minute to complete that. When we've had majority of people respond, we'll get to see the answers. Here they come. So before this webinar, 9% of you feel very confident, 41% feel somewhat confident, and 50% feel not at all confident in identifying the concerns about their client's ADHD. But in terms of supporting ADHD in your client, 5% feel very confident, 38% feel somewhat confident, and 57% feel not at all confident. Okay, good. You're in the right place. Let's see if we can change that by the end of this seminar. So next slide, please. All right. I have listed here some of the ADHD criteria that we use for making a diagnosis in our DSM. So adult ADHD traditionally used to only be diagnosed in children, but adult ADHD is a diagnosis that we use for those who are older than 17. Having said that, one of the things that's most important when you're making this diagnosis is to confirm that symptom onset happened under the age of 12, and that it's not just in one domain of that person's life, that it's in multiple domains, and symptoms have been there for at least 6 months. This is really important because ADHD is not something that you can suddenly develop later in life. ADHD is a form of neurodiversity. It's how your brain came to be, and it will affect you in different ways throughout your lifespan, but it begins right from early childhood. And so you would need to have at least 5 of the following symptoms from the inattention scale. So not paying close attention to details or making careless mistakes, difficulty sustaining attention in tasks, not seeming to listen when spoken to directly, failing to follow through in instructions or finish things, difficulty organizing your tasks, avoiding tasks you don't like, losing things a lot, being distracted by external stimuli, or being forgetful in daily activities. So 5 of those inattentive. And often we see people that just meet criteria for the inattentive subtype of ADHD. So they would just have the 5 criteria in there. The other part of ADHD is the hyperactivity and the impulsivity, in which, again, you would need at least 5 of these symptoms, where you're fidgety with your hands or your feet, or squirming in your seat, often leaving your seat when remaining seated is expected, running around or climbing excessively, difficulty playing or functioning quietly, always on the go, talking excessively, blurting out answers, difficulty waiting your turn, or interrupting in other people. So you can have a combined type as well, where you have both the inattention and the hyperactivity, impulsivity. and you can have the primarily hyperactive subtype as well. So different sorts of ADHD and variations. Next slide, please. I say that, and I listed out the DSM-5 criteria, but people think that ADHD is actually just trouble focusing and fidgeting, and there's so much more that's happening beneath the surface. So, in terms of, we think about ADHD, we think about usually young boys that are, causing disruptions in classrooms. But there's so much more to ADHD in terms of the symptoms and the functional impact that it can have. So things like difficulty maintaining relationships, trouble with regulating mood, things like forgetting to eat, sleep, or go to the bathroom, trouble focusing on things, even if they are of interest, and forgetting things a millisecond after they came to your mind. Something called rejection sensitivity dysphoria, where you're acutely aware of other people's reactions to you and have significant reactions back towards that. Trouble hearing things and processing things that you hear instead of actually seeing in a color-coded way. I think those are the ones that I want to, and definitely a sense of time blindness. Hyperfixation, people always say, well, I can concentrate on things for hours, but that hyperfocus is at the exclusion of everything else, which may require your attention, is a form of inattention or attention disorder. And so one of the things is that when ADHD can be very functional in certain settings where it's important to be able to respond to things immediately and with flexibility. But when you're placed in circumstances where there is increased cognitive demand, so there's more and more and more that keeps getting added to your plate with less and less and less environmental structure, for example, having a new baby in your family, this can lead to ADHD symptoms being exacerbated. So next slide, please. And so if we look specifically at women, of all people, about 7 to 10% of children are affected and 2.5 to 5% of adults. I suspect those epidemiology will change over time as we start to pay more attention to adult ADHD. But half of the diagnoses, half of the people who are diagnosed in children who are male do have persisting ADHD symptoms into adulthood, whereas 2/3 of those diagnosed as children who are female will have persisting ADHD into adulthood, which is unfortunate because, well, it's unfortunate for everybody, but the person who will get diagnosed in childhood will likely be male, so 3-to-1 referral bias versus female, 16-to-1. And that has long-term implications for not receiving treatment early in terms of social, educational, and mental health outcomes. So if we're looking at the different subtypes, definitely inattentive seems to be more frequent in females, and people with hyperactive and impulsive symptoms tend to be less severe. Sorry, I'm seeing things in the chat. Is there... Okay, perfect. Sorry, that's just for the panelists. So in terms of genetic risks, there's actually more vertical transmission from females, and siblings of females are often more symptomatic. Reproductive stages can actually be associated with exacerbation of ADHD symptoms, in particular premenstrual and perimenopausal. We hear about the brain fog in those periods. And then the antepartum baby brain, so direct impacts of hormonal shifts on ADHD. And then in terms of adverse outcome, that women tend to have, or females, I should say, tend to have greater impairment, tend to suffer more severe psychiatric illness and tend to have a greater lifetime incidence of psychiatric admission, as well as higher risk of alcohol and cannabis use disorder when they have concurrent ADHD diagnoses. Okay, so next slide, please. Thank you. Comorbidities are very, very frequent when people have ADHD. So in terms of general comorbidities, high rates of PTSD, traumatic brain injuries, obstructive sleep apnea, restless leg syndrome, which is particularly exacerbated by the iron deficiency in pregnancy, high comorbidity with fibromyalgia, chronic fatigue. We're starting to see a lot of literature around autoimmune disorders like Ehlers-Danlos and polycystic kidney disease. Certainly high comorbidity with autism spectrum disorder and different kinds of learning disabilities, which would have an impact on overall function as well. And then the classic triad of OCD, various kinds of tic disorders like Tourette's, for example, with ADHD. We call those, so the general form. If I go over to the internalizing disorders that tend to be associated with this. So I mentioned the rejection sensitivity dysphoria. This can often be confused or comorbid with borderline personality disorder or traits. Definitely generalized anxiety disorder, major depression, and an earlier onset of bipolar disorder and all types of eating disorders. Although certainly we see a lot of binge eating disorder, as like the eating is sort of giving you a bit of a dopamine hit, which is one of the deficiencies in ADHD. And certainly externalizing disorders, particularly in the hyperactive kids and adults. So oppositional defiant disorder, conduct disorder, antisocial personality traits or disorder, and substance use disorders, and not including internet and gaming addictions. So the next slide. Okay, so to make the ADHD diagnosis, is not just about doing scales or checking off on the DSM criteria. There's lots of different components that I think are very important to consider. First of all, ADHD is a clinical diagnosis, so you don't need to, if you are somebody that can make a diagnosis, it's not something that requires being referred for a full-on psychology assessment. Although I do think that that is really helpful in terms of assessing for comorbidities. The most important thing, though, is to start with history. And is there a family history because of the strong genetic risks for this diagnosis? It's also really important if you're inheriting this, that if your parents had ADHD, how was the impact on your attachment with your parents in your early and the impact that it had on your attachment style development. There may be a history of brain injuries, prenatal exposure to substances, as well as trauma, either psychological, sexual, physical trauma. There may be a delayed impact on developmental milestones, and that's important to understand, A, in terms of the environment, or B, if there's any comorbidities like an autism spectrum disorder, and understanding how a person did in their academics as well as in their interpersonal relationships can give you clues to what's going on today. You definitely, if you can, would like to get collateral, but I would say something that's super important is to be attuned to the cultural norms of that person. For example, we have in Indigenous parenting, depending on the society that people are growing up in, there's a heavy emphasis on autonomy and exploration and different ways of knowing, yarning as a mechanism of education as well as explaining, and shared caregiving amongst the community. So something superficially may actually look like ADHD, but when you put it into the context of child rearing in that culture, is actually quite normative. And it's when that person has been placed into a more, sort of non-Indigenous North American setting that you start to see symptoms of what might look like ADHD. While we're on the topic of culture, I would also give you examples from two resources that we'll talk about later, but I really love is Attitude Magazine and How to ADHD, which is a YouTube channel. And that when you have ADHD and you are part of a visible minority, there can be, cultural biases towards that that cultural minority. So these particular ones talk about how the Indian girl is, stereotyped as the well-behaved person that is high achieving, and then how that myth might sabotage their access to treatment and their access to diagnosis and care. The article that I'm referring to on how to ADHD, what it's like to be ADHD and also be Black, really refers to societal expectation of Black children and Black girls in particular, and a lack of attention or a pathologizing of it, and more towards bad behavior or punitive, and also being targeted to the justice system instead of receiving appropriate and culturally sensitive healthcare. So really important to consider the psychosocial, the cultural norms that of the person that you're assessing. There are several scales. I do have a slide coming up on that, but just be important to know that there are only a few of them available with female norms. You definitely want to look at current function and any compensatory strategy. So there's a lot of high performing people out there who actually do triple or quadruple the amount of work to keep up with the function that they play. And so while they may have had high academic or social or occupational outcomes, it might have been at the cost of a lot of work to get there, and therefore a lot of comorbidities. So you definitely want to assess for any comorbid illnesses. And I've listed a few there that I think are really important to rule out with any person with ADHD. Risk assessment is particularly important in this population. Driving and inattentive driving can be a concern. Because of sleep-wake cycles, co-sleeping with infants can be very common. Parenting, if there's impulse control or severe inattention, might be of concern. This population, because of the comorbidity, is much higher risk of suicide, and there might be more risk for being at the in a situation of domestic violence. Like I said, referring to a psychologist for a full-on psychoetic assessment is wonderful if it's available, and again, is usually privately funded, but not necessary to diagnose ADHD. I think that's where it's really helpful if there's concurrent learning disorders, or maybe comorbidity that you really want to tease out, like, for example, bipolar disorder or PTSD, where you'd need that psychology support. But to make that ADHD diagnosis it's a clinical diagnosis that can be made by all physicians, nurse practitioners, and people trained in diagnosis. So next, and then, before we say, I think it's really important to share the nature of the feedback, preferably in a written way, whether that's just a patient message or actually sharing the diagnosis, because I think a lot of people are coming to different healthcare providers saying, I think I have ADHD, or I was diagnosed as ADHD. It's really helpful to have some kind of official documentation if you have made a diagnosis of ADHD, especially when we're looking at all the orphaned patients in our community these days. And if they're looking to get refills on their stimulants, having because those are controlled medications, having that documentation is particularly helpful, as well as for their understanding of their disease. Okay, and next slide, please. So I did talk about the different scales that are available. Like I said, there's only the Connors adult rating scale, which has female norms, but that one is not free. I like to use the ASRS personally, but those are some different scales that are available. Next slide. And I'll pass that along to one of my peers to talk about the different kind of supports that are in play here.
Sure, and I think that peer would be me. So I'm Beth, for those of you who haven't seen me before. And if you've attended any of our education sessions or webinars in the past, you may have seen this slide. This slide is something born out of some work done at CMNRP and initiated by Christina Canton. And we've been really trying to use this type of an image or model to organize all of the different resources and just the way we think about what's out there for people, and also just kind of reinforcing the message that we're trying to get out there, which is that there are a lot of different types of resources available for people. They're not all, connected to specialist care or psychiatry care, that there are definitely other ways that people can be supported in their mental health, and that sometimes it's a combination of things. There's no right or wrong necessarily. And it's not always that sort of linear step that people might be able to find different resources from sort of along this continuum. And so I just have given a couple of examples on the next few slides, not one for every single petal in this case, but I do have a few. So if someone could go to the next slide. Yeah, the first one I have is an example of some structured therapy that's available. In this case, it's group therapy. And this is actually covered by OHIP. Physician referrals are required. I do know they book up quickly. So, the ones that have been in late 2024 were all booked up quite quickly, but they do keep a wait list. And then they do also seem to keep their website up to date in terms of opportunities that are coming in the future. So these are two examples where they have the IPT for depression with ADHD in parents and the CBT skills for ADHD in parents. And I'm sorry, there's a typo on that slide. But the next one that I have as well is Better Bria. This is an example of, Jasmine alluded to this, that some of these services are privately offered and do have costs. So Better Bria is online. That person can find them. They are covered. The services are covered by most benefit plans. But they offer a few different things when it comes to ADHD. So they do offer they offer initial assessments and then follow up. And then depending on that assessment, they will make recommendations. But two other things that they offer include OT therapy for ADHD and organization concerns, as well as a nurse practitioner medication management option for ADHD. So again, that would depend on those assessments and what's determined by them. So that'd be an example of more sort of specialist type of care. And then the next example I've included is more in the realm of peer support, which was another type of resource along that continuum. That's Postpartum Support International. This is free, this is online, and it is peer support, as I said. And they offer actually a wide range of peer support groups on different topics for different groups of people. And this one is specific ADHD support for pregnant and postpartum moms and birthing people. So those are just a couple of examples for you. And then when people do contact Ask Masi, based on what we learn about the individual and what's going on, we will try to suggest these or similar resources that may be helpful for them. And I think that that's all from me. And I'm going to pass it back to Jasmine.
Thank you, Beth. So, the bottom line is I think we do need more publicly funded options, but there's different therapies out there that are really, really helpful for people with ADHD in terms of figuring out how to regulate those emotions and manage the emotional roller coaster of rejection sensitivity dysphoria. DBT principles are really helpful. Cognitive behavioral therapy can be very helpful when we're targeting sleep, so CBTI, as well as the assumptions underneath procrastination and low self-esteem. OT coaching is something I really, truly wish was under universal healthcare, and I think is a huge benefit. So really looking at skills building with micro pieces of CBT and micro DBT skills, and learning how to triage different priorities. So yeah, like just so the time blindness doesn't affect that person is really helpful. And if you do have any recommended OTs that do ADHD coaching, we're always taking names. If that person is suffering from substance use disorder, we really want to focus on motivational interviewing, not getting them to the point of doing more work than they're actually at. So if somebody is, considering stopping a substance, but they're really not there, we just really want to talk about the pros and cons that substance is playing in their life. I find the same kind of interactions and interviewing skills are really important when we talk about medication adherence, particularly in people with ADHD, whether it's the treatments for their ADHD or the treatments for their comorbid situations. And they may need a lot more of the motivational interviewing because the memory and the follow through to keep up with the treatments may be challenging. Mindfulness-based cognitive therapy can be very useful for developing skills in distress tolerance and training one's attention. Apology for that typo there. So that's a helpful modality for, but I think that people may not necessarily be ready to jump right into MBCT. They may need to get to a certain level of function before they benefit that, but that is certainly a very helpful skill to develop. Environmental strategies, things like incorporating daytime movement, particularly getting out into the sunshine, having proper nutrition. Again, a space is missing there. Definitely things like blue dye and lack of whole foods based diet high sugar can be associated with worse ADHD symptoms. The Pomodoro method is an excellent method of sort of 25 or you pick your time interval, usually 25 minutes of task focus, followed by a 5-minute break. And then you actually have to set a timer to get you to focus on things like that. Having an accountability buddy. And as I mentioned, the resources, the Attitude magazine and How to ADHD YouTube channel. And next slide, please. Okay, when it comes to medication, we definitely have, and you've seen this slide if you've attended previous webinars, that we have lots of, and the same principles are true, that we really want to use as few medications as we can to minimize the number of fetal exposures. If we know something has previously worked, we want to continue on that. If something has already been prescribed through that early first trimester when organs are forming, there's not necessarily, you have to wonder if there's a point in discontinuing it or changing it up if we haven't had a history of previous success on that medication. If something is being given, it's an all or nothing exposure. We either want to optimize the dosing of that medication or we don't want to expose to medication at all. I have a lot of people that want to use the lowest possible dose. And as long as we're talking about therapeutic ranges, we don't experience significant difference between a lower dose. In fact, all you might be doing is exposing that fetus to symptoms of disease in addition to the medication. And so that's important when we talk about informed consent, is really helping your client to understand that it's not just the choice of, do I take this medication or not? It's the choice of, do I expose my fetus or my child and my family to my untreated symptoms, or do I expose them to the medication? And what are the risks and benefits to untreated disease versus the risks and benefits of treatment? And often you may have a really wonderful discussion with your patient, but by the time they get home, their partner, their family are not at all on board. So it's really helpful to have those discussions with everybody that the patient wishes to include, and you can really be an advocate on that level, whether you're a prescriber or not. And we certainly, I'm always really grateful when the allied healthcare professionals supporting a client can reinforce my discussions with my patients. Next slide, please. So I'll go briefly into some of the medication specifics. There are four different categories of ADHD type medications. There's the methylphenidate-based psychostimulants. These are things like Ritalin and Concerta, and it's important to remember that they have racemic mixtures of the D and L enantiomers in certain formulations versus the isolated active enantiomers in other formulations. Methylphenidate does not seem to be associated with increased risks in animals. There was a meta-analysis in 2020 showing a slightly elevated risk of cardiac malformations, a odds ratio of 1.59. I will add that there's been a lot of these studies were looking at abuse situations, so where medications were not being used in therapeutic or prescribed situations, but actually being overused or in an environment where they were not indicated. And so some of the results that came from some of these studies may not be applicable to a therapeutic situation. This comes up later in my slides, but I will mention it now, that there was actually a very reassuring meta-analysis that came up earlier this year, published in JAMA in, I think, January, February of this year, that actually showed that prescribed psychostimulants were actually not associated with birth defects and did not show any differences in behavioral outcomes in children. That was Suarez et al. So that's actually a really reassuring piece. Methylphenidates in particular may reduce serum prolactin, so something to keep in mind in terms of breastfeeding effect. And the immediate release dosing is probably, in general in pregnancy compared to outside of pregnancy, we like to use immediate release and medications with shorter half-lives. So say the Ritalin as opposed to Concerta, to use trade names. And that's because they're metabolized faster. And also in the postpartum, if you're breastfeeding and you wanted to use the medication, you can actually time things so that you're using it when you need to be awake, because, sort of the day and night stuff doesn't mean anything. So if baby is waking up at is awake between 4 p.m. and 8 p.m., that's a great time to take your short-acting methylphenidate in order to be alert and have attention during the time that your baby needs you. Low excretion rates in the populations that we do have studies on, but just a few case reports there. Next slide, please. Amphetamines, just keeping in mind that these have street values, some depending on the formulation, and some of these are prodrugs. Again, a lot of the information that we got on negative effects has been diluted in the meta-analysis that was published earlier this year. But in the context of abuse, there is some negative impacts on fetal development, as well as neonatal withdrawal and variable excretion rates into breast milk. Again, if you're using medications with shorter half-lives, in this case, some of the very short half-lives can actually be, like the dexedrine, can be used in a pump and dump method where if you can time things that once you've taken your medications at the peak plasma concentration, which would be, for example, for dexedrine, and in about 2 to 4 hours, that could be pumped away and dumped, and then the remaining wouldn't be the remaining breast milk wouldn't contain as much of the stimulant. Having said that, pump and dump and sort of measuring all of this, when is the peak concentration, when am I going to feed my baby, and even just the act of pumping and storing breast milk may be just too much of a cognitive burden for people with ADHD. Next slide, please. Atomoxetine is a non-stimulant NRI known as Strattera. The slow metabolism exposure to feeders can be higher. Some people are fast metabolists of this medication. Not a ton of information, though, mostly from animals. And next slide, please. Guanfacine is an alpha adrenergic blocker used in antihypertension. Something to consider that especially if there's a comorbid preeclampsia, that we may want to consider this medication to get 2 in 1. Okay, next slide, please. Bupropion is something that I really liked before this JAMA article that I keep talking about came out, where it's more of a third-line ADHD treatment. But if you're using it in somebody with, say, depression or who's smoking cigarettes, that it's actually can be quite beneficial to their ADHD symptoms and has low excretion into breast milk. So something that I quite appreciate. Next slide, please. This is a snapshot of the CADRA prescribing chart on the left, which gives you doses. So CADRA is our National Canadian Association for ADHD, and I encourage you to Google it. It's freely available. And here I have a screenshot of that, finally, the review article that I kept referring to for your further reference. Next slide. And I will hand that back over to Beth.
So again, for anyone who has joined us in the past for webinars or sessions, this may be a diagram you've seen before. And the reason we include it, regardless of whether we're talking about depression, anxiety, ADHD, is it really is just a reminder for everybody about the goal or one of our main objectives with Ask Masi and why we are available is all just to sort of demonstrate our hope that with a program like this, people are able to feel confident or know about appropriate resources that they can initiate early on. And so we always just try to say, it's not necessarily ideal if something's identified and a referral is made and a person then is waiting to see a specialist when that may not be what they need, and then when they are potentially not receiving any interventions in the meantime. So you can sort of see what typical care as usual might look like. It's not specific to ADHD in this case, but it's just to sort of demonstrate sort of what can happen when we're not putting something into place earlier on. And so with Ask Masi, what our goal is, and I'm going to give a couple of examples of encounters that we've had, that people know about some of these resources that are available, and that as soon as something is identified, whether it is, information or some kind of self-directed learning or peer support, that there are resources out there, and it's not a matter of, I'm going to make a referral to someone who knows this better than me, and then that person will just wait to see someone else. It's all about what is appropriate, what can we connect this person to right away so that they're not just kind of left to wait. So that is why we include this slide, and it's just a reminder of what we do. Anybody can contact us if you're involved in providing care to a patient or client, and we will always try to tailor what we're sharing with you based on what's happening with your client or patient. And it doesn't matter what type of clinical role you're in. That's what I always like to say as well. The only real call that we can't accept is directly from a patient or family member themselves. So regardless of the clinical role that you may find yourself in, whether it's connecting just with the initial person like me about resources, or if you're a nurse practitioner and physician and speak with Dr. Gandhi around maybe more of the diagnosing and prescribing and psychiatry component, that's why we're here. So on the next slide, I have one example, and it was a really interesting example of a time where we actually got calls from two different healthcare providers at two different stages in this person's pregnancy journey. So we did get a call from the nurse practitioner when the patient was 27 weeks pregnant. They already had a diagnosis of ADHD and anxiety, but hadn't been taking any medication for a couple of years, and they were experiencing an increase in panic attacks. And I'm going to encourage Jasmine to jump in if there's any clarification she wants to make around the conversations that she had with these providers. But in this case, the person had tried a number of medications and didn't have much response. And so at that point during pregnancy, at 27 weeks, the conversation was around starting escitalopram at that point in time. And then we did get a different call 2 months after the person had had a baby, and they were seeking assistance managing ADHD and lactation. So there were some conversations around increasing her medication. And to Jasmine's point about a possible adjuvant, they talked about adding bupropion. And then definitely part of those calls involve just some shared education on key teaching points. So anytime someone speaks with Jasmine, it's a great little mini kind of one-on-one teaching coaching session, all the different little nitty-gritty pieces to maybe know about prescribing and pregnancy and lactation, and some teaching around those medications. And then also a good chance to talk about those, maybe lifestyle pieces that might be helpful. So really kind of getting into some practical tips on sleep protection and sort of those skills and things that Jasmine's touched on already today. On the next slide, I have an example of a call that we got from a physician's assistant. And this is a pretty typical type of call. And so I won't read the entire slide to you. And it really summarizes a lot of what Jasmine's covered today throughout the webinar. But, if you're ever out there looking after a patient or client, and maybe you're not their prescriber, you're maybe not their family physician or the person that is in that role, but please know you can always share the word about Ask Masi and encourage them to give us a call if they're not feeling confident about managing this. This is the type of call we might get. Somebody who's 10 weeks pregnant, they want to ask about the safety of Vyvanse in pregnancy. And this is where then we would connect that prescriber to Jasmine, and Jasmine would go through, similar to what you've heard today, sort of the risks, benefits of untreated illness versus different medications, and all of the different factors involved in pregnancy and these medications, and we're not using medications. So that is just a pretty typical example of calls we might get. And I do have to say, we do get more, or most of our calls are around anxiety and depression, but it is not an insignificant number of calls that we get with questions around ADHD. And if you would go to the next slide for me, please. I will say that we actually even adapted our documentation a little bit, because sometimes, people have contacted us and they do have a diagnosis. But in some cases, what people are just describing to us, or patients again thinking that they may have ADHD, that's not uncommon for us either, where just sort of what they're describing is, maybe cueing us to say, this may be something to consider. And so, and also, I just included these quotes because I think it does really reinforce Jasmine's point earlier about if there, is a diagnosis, if there is anything on paper that can be given to your patient or client that they have and can kind of keep with them as part of their healthcare journey. We do hear things like, my patient thinks she has ADHD. She's tried a sibling's medications and found them helpful, but she's scared about the potential for addiction. And another example, and this is not uncommon for us to hear about as well, people that had been on medication and decide to stop taking medication. And this is the case, we hear about it for anxiety and depression and other things as well. bipolar disorder, but people maybe stopped taking their medication, and now they're describing their symptoms becoming more problematic, worsening function, and people trying to advocate for themselves with their GPs. But in this case, unfortunately, they weren't getting very far, and they were told that they were med seeking. So these are just examples of the things that we tend to hear about. I wouldn't be surprised if you come across some of these things in your own practice as well. And so just to let you know that these are the types of questions that we might get, conversations we might have, and that's why we're here to see if we can help sort of advocate and move the conversation along as well. So I think I will wrap up with that, but Jasmine as well, please feel free to jump in on any of those examples. And I think we've left plenty of time for questions.
Thanks, Beth. So please do send us questions in the chat. And I think we've got another poll of just asking you how your practice will change. Here's our contact information. If you scan that QR code, you will get our contact information, and it may take you to our website just for you to jot down. But yeah, wondering if we've changed any of your confidence in identifying concerns about your patient and client's ADHD, and how confident you feel to support your patient or client's ADHD having attended to this webinar. And looking forward to answering any of your questions.
Thank you so much, Jasmine. I always learn so much when I listen to you speak, and I think there are some key points that I heard about, importance of having a diagnosis, having it written down, so that follow-up providers could actually continue the medication prescribing when it was indicated. And you mentioned orphan patients, and that's a real problem right now that a lot of families are experiencing, right? So that continuity in terms of their treatment is a significant issue. So I think that was a really important point that you highlighted. There's a question in the chat about wondering if you support ASD assessments, because ADHD and borderline personality disorder always makes me think of autism spectrum disorder for females. So can you comment to that?
Absolutely. Great question. So high comorbidity. Certainly in Ask Masi, you could absolutely call us and we would be thrilled to talk about that and the components involved in that. That is a separate and different diagnostic procedure. So, and different people may or may not feel comfortable with doing that, but absolutely help. Very happy to support having a discussion about that.
Yeah, and isn't it amazing to have Ask Masi as that specialty expert advice that we can just call and get some help right away. So that's a great example. Thank you. And during your presentation, you really differentiated between therapeutic versus recreational. And when I started offering the perinatal substance use workshop, this was a question I got all the time, because people would hear about the effects of stimulants on the fetus and the baby and the concern, but the difference there was just the dose. In a therapeutic situation, you have a stable dose that's prescribed within an appropriate window, and in a recreational situation, like we're talking sporadic doses, high doses, this is where the concern is. So I think you described that very clearly a couple points through your presentation about, we can safely take these medications for a diagnosis like ADHD. That was really great. And I don't see any other questions here. I'll just keep chatting for a couple minutes. I love the point that you say about optimizing a dose. So I think a lot of people know that I'm doing my PhD in nursing right now, and I'm really looking at antidepressant medication exposure in pregnancy. And I'm definitely seeing in the literature that people will try to do like smaller doses, low dosing, and it's suboptimal, it's subtherapeutic dosing. So they're not getting the benefit of managing whatever mental health condition that they have. And then there's this exposure. So I think as the guidelines are released in Canada, so the SOGC guideline was released in October, and then the CanMat guidelines are coming out. I think that's really going to help providers. But again, you can call Ask Masi to get advice about the medication you're thinking about the dosing that would be indicated. And I think a lot of people are finding that helpful, right, Beth and Jasmine, in terms of like, this was my idea for a course of care, and really helpful just to reinforce.
Yeah, I would definitely say that a lot of, actually, Beth, you may know more, how many percentage of people are feeling like they confirmed their course of action and just really appreciated having a second opinion so that they could document that for their own medical legal liability, or sometimes getting a new course of action just to be able to move forward with something that they hadn't thought about before. Absolutely.
Yeah,
And
the feedback in that regard is positive, and I don't want to say it's 100%, but out of the few options that we provide on the survey, they all will say that they feel yes, either more confident about what they were planning to do, or you've given them some different options. Especially I find, we'll try A, and then if A doesn't work, you may want to consider B, and if B doesn't work, you could try this or call us back. And I think people find that quite helpful.
Yeah. That's awesome. Another thing that I heard about you say is that ADHD is a clinical diagnosis. So nurse practitioners and family physicians can make that diagnosis. Other referrals to other specialists could be helpful in terms of just really understanding the comorbidities. But again, just thinking about different roles within our healthcare system and really needing to like maximize these opportunities to get the help that people require in a timely manner. There is a question that came through. Any thoughts about using reflexology and yoga as part of integrative therapy complements?
Great question. So I can't say that I have any expertise to talk about reflexology. So I'll defer that one because I think there are probably people better positioned to answer that. But in terms of yoga, like on two different aspects. So there's the movement and the focused movement, which can be really helpful, as well as the mindfulness component and like of yoga. So there's so many versions of yoga, right? But if you're practicing yoga that is really present focused and looking at drawing your attention to certain movements and positions of the body, that is akin to what I was saying about mindfulness based cognitive therapy. That is very, very helpful for training the attention. These can't be curative. I will actually say that, and to follow up on a point you just made, Christina, is that ADHD is one of those diagnoses where we have really high success with medication when there is a proper diagnosis, really, really high success. And to get to a place, the skill buildings, non-medication interventions can certainly be helpful, but none of it is curative. And often you'll have to get a person to a place where they can benefit from the non-pharmacological interventions. So I wouldn't pursue yoga as a first pass. That might actually be quite frustrating for somebody with ADHD. Just like I wouldn't pursue mindfulness as a first pass, but I would see it as a very important complement to their therapy, their overall treatment.
Thanks so much, Jasmine. I'm going to turn it back over to Catherine to wrap up the session today.
Thank you. So I think we had just one last poll in terms, this one is more of a personal reflection for your own in terms of effectiveness for this webinar. So on a scale of 1 to 5, how effective was this webinar at meeting your learning needs? So not at all effective, somewhat effective, effective, very effective, or extremely effective. We just like to answer, to ask you the questions so that we can maybe change or do anything as well. So we are open to your feedback. We won't share the results. As I said, this is personal, but just wanted to take the time to thank Jasmine, Beth, and Christina for just being here today and taking the time to talk about ADHD and anything perinatal mental health so important right now. So we thank you for being with us during your lunch break as well, and just keep track of the recording that will be available on the CNRP website as well. Thank you so much.